Thank you so much, everyone. This is the last session on retina. It's on vitreomacular surface disorders, and it's a panel discussion. And please feel free also to tell us your questions and your feedback. And I would like to welcome the panel: Dr. Ahmed Magdi Bidda from Alexandria, Egypt, and Dr. Deependra Singh from India, and Dr. Ibrahim Al-Gharabli from the UAE, and Dr. Muhammad Adallah from Cairo, Egypt, and Dr. Abdurrahman Badawi from KKash, Saudi Arabia, and myself, Ahmed Salem. I just start a quick introduction here. I tell everyone that I'm one of the only few people who know why the vitreous is there is to keep us employed. Because if you look here, the main reason all these happens is because of a vitreous related to the vitreous, right? So if the vitreous separates abnormally, you get all these disorders. I've just focused here on the vitreomacular surface disorder. So that's why the vitreous is there to keep surgeons employed. So my first question to the panel, and we can start from Dr. Badawi here, and we keep going this way. You have a vitreomacular traction case. My question is, when do you operate for these cases? Do you operate everyone with vitreomacular traction or symptomatic cases only? And when you operate, do you peel the ILM or you just induce vitreous separation? So Badawi.
Thank you so much, Dr. Ahmed. We always learn from you. So I think symptoms is very important for the patient. If the symptom is increasing, is worsening, this is really a strong indication for vitrectomy. If the patient is asymptomatic, I would not be keen to do the surgery, but if it's progressive and I start to see the retina is more pulled over and more, the anatomy is not maintained, and the photoreceptors start to be affected, especially in diabetics, I would go for surgery after proper counseling for the patient, and that surgery may be early better than delaying it for a long time and have worse outcome later on. But usually symptomatic and asymptomatic with worsening vitreomacular traction.
Excellent. Dr. Gharabli, question, peel or no peel the ILM? So we're going to go for surgery. Symptomatic patient, maybe give them a cooling off period, and then if they are symptomatic, go for surgery. Peel or no peel? For
it depends, as I say, just if there is epiretinal membrane, you will peel.
No, let's say no epiretinal membrane.
Pure VMT?
Just pure VMT, like picture, maybe like the second picture up there. Yeah. Peel or no peel?
As I said, if you decided to operate like the third or the groove in the right-hand side, definitely I'll not go for ILM peel here, as long as there is no epiretinal membranes. But if there is epiretinal membrane, I always prefer the double peeling with ILM.
Double peeling.
Due to the recurrence of the epiretinal membrane.
And Dr. Bidda, what would you do, like if it's just only vitreomacular traction, like one of those two?
If only vitreomacular traction, I would go for removal with vitreous without ILM peeling.
And Dr.
In the past, I used to peel, but we struggle with edema. So there are coming studies, and there are already studies that peeling increases the incidence of edema. You are going to struggle what to inject, and
yes.
So I just remove the ERM
if
combo.
There.
And if ILM comes with the combo, it's okay, but I don't insist on.
Thank you, Dr. Abdallah. And Dr. Singh,
I peel like
you peel even if there's no epiretinal membrane.
Yeah, only difference it makes is fovea sparing versus fovea involving.
Okay.
So,
all right.
So I think I look at the tissue at fovea. If it's thinner, I would definitely spare the fovea.
Spare
but
the
if
fovea.
It's significant, good amount of tissue, I'll peel across.
Excellent. All right. Any question about vitreomacular traction? We'll move on to epiretinal membrane. So lots of this staging of epiretinal membrane. I just put them here. I want to stop, and this is an on-fast picture, so that's stage 1, stage 2, where you start getting more than the membrane, and you get like loss of the foveal dip, and then here you get actually inner layers moving to the fovea, and then stage 4 where you get disorganized tissue. I just want to stop about this sign, and this is where actually, the more I look into the OCTs of epiretinal membrane, we see more this here with schisis of the nerve fiber layer, and this actually what happened is because of traction, you get schisis of the nerve fiber layer, and it has a bit of implication, as I will ask you and see what you think about this later on during the peel. My question is, my question is, Do you observe this sign like frequently in cases, the nerve fiber layer crisis? Does it change anything you do, Dr. Gharabli?
Can you hear me? Okay.
Yes. Yeah. Ye-
This is a great presentation for the patient, great straight away. And let's say that usually
No, yeah, no, sorry. مش قصدي على I don't mean the classification. I mean this sign of nerve fiber layer schisis. It's just the sign, like this here. And sometimes actually you see it with like early stages, like it can be stage 3 and you have this nerve fiber layer schisis. Anyway, we'll talk about it here. Let's go to another sign. We'll come to this one. Something as well we see, and I used to think that this patient has a double pathology, has the membrane as well as like AMD, but actually sometimes you can get outer layer changes that may look like an AMD just because of the epiretinal membrane. And the reason is you have these the molar cells and the arrangement of the parafoveal molar, and when traction happens, you can get this actually configuration like this. And until like few years back, I used to think that these patients have epiretinal membrane and some sign of macular degeneration. So I think just for some awareness that even from epiretinal membrane, you can get outer retinal layer changes like this, just because of this arrangement of what they call the central foveal bouquet. And that's central foveal bouquet abnormalities. Yes, sir.
Actually, there is a very interesting study regarding this, and they applied physics in order to show that the stress and strain, it's
Yes.
purely physical. So the study goes as this: you apply force in physics to the surface on a tissue very similar to the retina, and they were surprised that the stress and strain is the maximum at the base. So this explains, if you apply force at the surface, it's very interesting slide. I will send it to you.
Yes, please.
It's if you apply on the surface force, then the first layers to crack, not the layers next to the force, the layer far away from the force. Especially, you get strained between the wall of the globe and the stress. I will send you this as a pure physics.
That's very interesting. So I think what to take from this is, this actually can be just from traction. Okay. Next, and we'll come again to the nerve fiber layer schisis sign, which is interesting. But the question that I was speaking with Dr. Gharabli outside about this, simultaneous versus sequential cataract vitrectomy surgery. Let's focus on macular disorders. Maybe we can ask the panel here. So, Dr. Badawi, do you do simultaneous vitrectomy, cataract? Let's say in general, and then for macular disorders, or for macular disorders, macular hole, epiretinal.
If it's not significant cataract, I prefer to do, sequential, because maybe the gas or air will induce more cataract later. But for macular hole, always I try my best not to do phaco with the macular hole because the gas might be affected and migrated anterior chamber. So in general, but if there is air tamponade and have or fluid sometimes for like epiretinal membrane for PMT, it might be if there is significant cataract, but usually sequential.
Actually, it depends on the age of the patient. Okay, what I'm saying is if your patient above 55 or whatever, you know that after doing this surgery with the gas, the cataract will come within few months, believe it or not. So the big advantage of doing simultaneous, first of all, you can do proper shaving of the base of the vitreous, and this is the biggest advantage. It will give you better view because sometimes there is peripheral cataract, even you think it's clear, but it's all the peripheral view is there. Third, you will avoid doing this surgery later on to the patient because with the gas, definitely you will have the cataract. Why you do surgery later? So with hole or without hole, as long as you are going to put gas or silicone, I always prefer to do simultaneous, as long as there is no other issues with insurance, political, whatever.
So simultaneous, okay. Dr. Bida?
I would probably do the same as Dr. Gharabli. Patients above 50 years, I go for simultaneous.
Okay. And most of these patients are above 50, so I think that's the point of discussion. And Dr. Mohammed, combined surgery as well?
Exactly, simultaneous, especially if you are going to do air tamponade, it allows a big space for
Okay.
a big bubble and less of the prone position.
Okay, so saying I see you
Yeah,
nodding.
I think I also can add that too. I think I agree with all the co-panelists that sometimes I get a stage 2 in a very early cataract. So I may not jump for immediate surgery, but whenever I do, I will go for a combined surgery. Sometimes I tell them let both pathology reach a level, when they reach surgery. So both are in early stage, not much of metamorphopsia, but yes, combined.
Okay, so Dr. Badawi, you're out of alignment here. I'll tell you what I do. Sure. Yeah. Yeah. I don't know. I mean, that's for me luxury. Toric IOL for a macular hole.
know.
That's even luxury.
Toric IOL in the vitrectomized, it has the prone to rotation. If you
Yeah.
rotate toric IOL for like, suppose it's he's for example five cylinder, and you put toric IOL, if it rotates like the slightest, it will cause a lot of trouble for the patient, especially with a patient with macular function affection.
Definitely with any VR surgery, I think the golden rule is, not to try any of these refractive fancy things, either multifocal or toric or any of them. Just monofocal, you have a bigger problem at the back of the eye, whatever the reason. So definitely, as you said, it's luxury, big luxury, and it's not needed, and it can make the patient's nightmare later after the surgery.
Right. Any comments from the panel? Before I'll tell you what we found and what we do, but any comments? Yes, please. So we're gonna come to this point. That's a great point. This is actually a great point. The vitreous-based shaving and for in macular disorders or not. So I'll tell you what we do, and that's what we found. We found actually the problem, as Dr. Ghorabli mentioned very nicely, and the esteemed panel, is that if you remove the vitreous, you have bigger gas fill, you see better, but the surgery is longer. But again, it's better use of the time. But what we found something really, when we looked at all patients who had combined surgery, we found that there's 9 times more increased risk of having an IOL problem. And I think it's mainly related to the gas, because when we repeated the same study, but we only focused on epiretinal membrane surgery, where usually you don't put gas, we did not find this. So usually what I do in my practice, if I'm not going to put gas and maybe epiretinal membrane, it's a nice, easy surgery, there's usually PVD, then I would do combined surgery. But otherwise, I don't do combined surgery. And I do like Dr. Abdurrahman, and just separate the surgery, deal with the macular hole later, and then later on do the vitrectomy for them. And I think it's all related to the gas, because with epiretinal membrane surgery, we did not see that. Okay, we'll move on to another question. Yes, so this is the patient, and you can see here, actually, it's not like very advanced, but there's this sign. The internal limiting, this nerve fiber layer schisis, and with that sign, there's an internal limiting membrane dehiscence in this area, because that's where the schisis happen. And that's important to note when you peel for a reason, and to be aware of that sign, which actually in one paper they found that 20% of their epiretinal membrane cases has that. So this is not very advanced, not like a stage 4, but it has this sign. And the important is that at that area, there's a dehiscence of the ILM. So don't try to peel the ILM if you want to peel the ILM in that area. It will show here down here. So the retina is thinner in this area. And you can see here, this is the case we're doing. And actually, we did not hold the retina. We just hold the epiretinal membrane, and it created a tear. It created a stretch tear. And I looked at this case like several times with the fellow, and he did not really hold the retina. He was just pulling. And when it happened, and it's an area which is thin, and you can see here it's more like an inner layer tear, just because the area is thin there. And then we just put gas in, and patient did well. But I think the point here is you have to be careful about this area, because it's an area where it's thin, and don't try to peel the ILM in that area. And also, if you look here, just be wary of the appearance, because you may think that this whitish area is part of the membrane, but this white area is the nerve fiber layer. Yeah, so don't try to peel that area. I think that's the message. Right. So nerve fiber layer schisis, be wary of this and its implication. Any comments from the panel on this, the nerve fiber layer schisis, or?
Did you get a full thickness?
No, it was like inner layer. But even if you get full thickness, usually I would not laser them and just put gas. Although one case that happened in diabetic, and the patient actually developed a retinal detachment. So that's the only case I saw where a problem happened from this.
Usually, right?
Please, Dr. Bedar, go ahead and go.
Usually breaks in the central area do not require.
Yes. We were surprised actually in diabetic, and that's where we stopped all peeling and ILM in diabetics, really. Which again, yeah.
One thing which helps me is that watching OCT just before the surgery.
Yes.
I think normally I ask my assistant or somebody to click a video of this raster scan, and I just before I start, I tell them show me the scan, and they show me on phone. And recently there is a publication where they have added a VR headset to surgeon, and actually when he's operating, I think he is able to see, just like and they have incorporated OCTs into Ngenuity kind of system.
Yes.
But I don't think you require that. That's too expensive. You just
Yeah.
see just before your surgery, so you can know where to pick.
Yes.
That helps you.
Or at least where not to pick. Yes, and again, we do this as well. We always open the pictures on the computer in the operating room before the surgery and look at them. And with the attachment, we open the Optus pictures as well.
Quick thing, actually, but we need to differentiate between different types of epiretinal membrane. What I'm saying is, an idiopathic epiretinal membrane, usually you will not have this, but for diabetics, for example, you need to be more careful because some areas are, as you say, just nothing. And there is epiretinal membranes with uveitis, and so with the diseased retina, this is where you need to take your attention and look better more. But with the clear epiretinal membranes, you are fine. The second thing is, even if you don't have OCT, intraoperative OCT, as soon as you find some sort of traction or some sort of this is where you need to stop. Okay, you don't need to make any traction.
Yes, yeah, these are great points. Yeah. Okay, well, I think the next point we already, I think, touched on it, is the whether you're gonna do an epiretinal membrane peel only or do like a double layer. And I think we've heard what the panel do, and that's a mix between epiretinal ILM peel and only if it comes as 2 layers, and all just leaving the ILM. And what I tend to do is I just peel the epiretinal membrane, I leave the ILM unless it comes with it. Okay. And then you can stain and see it, but I stop peeling the ILM. Okay, I think this is Dr. Abdurrahman's case. Abdurrahman, do you want to, I can do the slides for you if you want to come here, whatever you prefer. Yeah. Please.
So thank you to Ahmed for the sharing. So this is the 51 years old. I will just go quickly for sake of time. Diabetic with a history of laser for the PDR, and have a complaint of drop of vision for the last 7 months. So this is the OCT. There's an epiretinal membrane with a very fibrinous like appearance of the posterior hyaloid. You can see causing BMT with a lamellar whole thickness and disruption of the autoreceptor. This is the color from this photo. You can see the laser mark, and you can see the stuff like shrinking of the macular area due to the epiretinal membrane, and you can see that also there's an exudation in the inferior temporal quadrants. Any thoughts about the exudation and the lesion here in the inferior temporal? I would like to have. Yeah. So we did FFA for that area. Thank you. So we did FFA to that area to make sure, because she was referred for a possible secondary vascular lesion, and we found there is a leakage in the late ferns of that area. So we thought that this is vasopressor tumors, which was treated previously with laser when they're doing the PRP or elsewhere in other facility. And I think the epiretinal membrane and the BMT is secondary to the contraction of the hyaloid because of the laser as well. So we went ahead. In this case, there is a significant cataract, so we remove the lens and we put IOL, and I will just go forward. And then we went to the vitrectomy. There was a lot of adhesion, and the hyaloid was really fibrinous-like in appearance. We put Ramsay, we did not found any good staining for the posterior hyaloid because the hyaloid was really stuck to the macular area with a lot of adhesions. So we think that was a good idea to put membrane blue and to stain the hyaloid as well as the epiretinal membrane. So we removed the fibrotic tissue over the disc, stained with double membrane blue. And then we can see here we detached the hyaloid using Eckert forceps. It was really adherent, and you can see the propagation and the wave going forward. And once we achieve good detachment of the hyaloid, we start to cut, and you can see the fibrotic membrane here came once we detach the hyaloid. Then we peel the ILM because there is some lamellar also macular hole thickness, partial macular hole loss and defect. So we peel it, and we then treat the vaso-occlusive tumor that was previously treated with cryo to make sure there is no oxidation later on. So we just did some shaving, clearing all the vitreous around the vaso-occlusive tumor. This is the cryo, just testing the cryo, make sure there is enough freezing and it's tested properly, and then cryo over the lesion and leaving the patient under air only with endolaser for the proliferative diabetic retinopathy. Thank you, Ahmed. So
I think you have most of the slide.
yeah. Can we go to the slide?
I think next.
Yeah. So this is the OCT. Sorry, it was just last week, the OCT, and you can see the vitreous macula traction is gone. The macula start to go back to its normal configuration, but there's some loss of the photoreceptors. But the patient did well, and the vision improved to 2100. She was 20/200 before the surgery.
And you only left air.
Yeah, only air. Yes. Just for the closure of the sclerotomy. So I don't put any stitches. It was 25 gauge.
Abdurrahman, in the preoperative photographs, I think one photograph showed the presence of a full thickness macular hole, isn't it?
Yeah, there's a partial area. Yes, there's a focal
There is
area.
a full thickness area. So in these conditions, don't you go after removal with the epiretinal membrane to peel the ILM also?
I peeled already. I peeled the.
Removed.
Yes.
Since
it is small, I just peel the ILM because there is one study showed that complete removal of the ILM is better than temporal flap in small holes. So in small hole, I tend to peel the ILM hole, and the big holes I do temporal flap or inverted flap. Correct. So this is the ILM. Yeah.
Only this, because the flap started to be like a trend. Okay. And no one looked at the big study which has been done in Manchester, actually looking for the macular holes, which is less than 400. ILM peeling is just giving you the 100% approximately, even just the whole thing. Because sometimes even with the flap, you can hit easy the retina while you are trying to put this and this, and you are complicating things which should be easy, straightforward. For a big hole or long-standing hole, maybe you can think about the flap, but it doesn't have to be in every case, to be honest.
Yes.
Yeah, I think that speaks to the. Sorry.
Yes, I think the reason is why because the fake adductors.
Even for full thickness macular hole, you can still use air, by the way, because it's closed within 72 hours.
I'll come to your slides in a second, because the discussion started. So actually, maybe we go because it's an epiretinal membrane. We stick with that. Yes, I would have probably used the gas, but it's fantastic. So I think with Dr. Singh, do you want to come from here and present? Okay, all right. So again, on the same discussion about epiretinal membrane, Dr. Singh has this very interesting case. Stage 4 ERM. Okay, I'll play the video. Yes. Thank you so much.
ERMs and your foveal contour doesn't come back. Although many times they still recover good vision 6/9 despite that lack of foveal contour. And in our own study, almost 50-60% of patients EIFL persists even after good peeling. ERM and ILM, EIFL would always persist. So I just thought let me try their technique. To be very frank, this was the only case and first case. So, and normally I inject this subretinal drugs or VSS manual. Somehow automated So you can see some tremors initially, but after like that, I'm stabilized. Now, I was not sure how close I should go to fovea. I was worried about foveal blow. So as you will see the first flap, I made quite far, and I will not recommend going that far. Really, this flap didn't do anything. And then second flap, I made closer to fovea. And, I think we should have smaller, shorter 1 ml syringes, one less than but then I could make that flap. Gently, I was also not sure whether I should treat it. Okay. Can you give it up?
Yes, the post-ups, yes.
You can see quite disorganized inner retinal layer preoperatively, but as early as 2 weeks, some foveal jetting starting and visual recovery also quite good. And if you can do those scans, you can see that site of injection also. Maybe one of these scans. And all of you know that those 41 gauge need not be laser. They see as far as this the whole idea of healing ILM and ERM, how I decided I stay with BBD and try to see the extent of ERM by negative staining. If I see that it's a very small area of ERM, then I start dealing with ILM itself. And so my whole idea is that for smaller size ERM, I don't want to grasp closer to fovea because every time I grasp, I'm creating a photo. So I try to peel near the arcade, the ILM, and many times you can successfully remove both ERM and ILM together and in one go.
Yeah.
And in a very controlled way. But if I have an extensive bigger ERM like this, I'll do exactly like you do that. Remove the ERM first and then remove the ILM.
That's a good one.
Yeah.
Right.
Actually, it's a nice idea, but do you think, okay, I'm not sure in the long run, or they have many number of patients over the long run, whatever, the number of complications which is coming from procedure like this, I don't know how much. Especially, as you can see with the touch of the retina, there's bleed there. I'm creating a bleed where there is no bleed. And even in epiretinal membrane, yes, the picture maybe in the beginning, it will be, the configuration is not there, but after a long time, they settle and still they have good visual acuity. Do you need to create this exactly?
In fact, I have used this technique of retinal hydration patients after failure of initial macular hole surgery, and it really works fine.
Yes.
But in such cases, I always remove the epiretinal membrane without doing
Yes, I've done this as well, and I think it's nice. You do the hydrodissection. I close the hole with a bubble of PFCL, and then I do the hydrodissection, and you're bringing more retina from the periphery, and it makes the hole smaller. Then you put gas in. I think that's nice end-to-end closure for large macular hole. And I think that's a good point. Maybe stage 4 epiretinal membrane, maybe that's something worth trying. Yeah, for a big hole. Yeah, big hole, it works very well. Yes, because you get the primary closure rather than putting a graft. And I think something as well we learned from subretinal injection, few things to decrease the risk of a hole. If you're doing subretinal injection with no hole, you want to inject slowly. You also want to be looking at the fovea very carefully because it stretches very much. And the other thing is to do it slowly and at a very low pressure. I usually use automated, but very low pressure. And you may put still a bubble of PFCL on the fovea just to try to get some counter pressure. But the main thing is inject slowly.
So the aim is to do primary closure.
Yes, you aim to get, when you hydrodissect, you're getting, yes, and then you actually, you have to like aspirate gently through the hole without touching the RP, and you do it several times, and the hole you can see it getting closer. Yeah, I try not to massage. I try to aspirate over the hole, but don't touch it. I don't know what, Dr. Ahmed, what do you do? Do you massage as well or no massage?
No massage at all.
No massage. Yes, so that's another technique. I was going to talk about this or touch about this. So macular hole, I think that we'll come to that point, but this is with macular hole. What do people expect with macular hole? Do you have PVD or no PVD when you have a macular hole? Any thoughts? Okay, Dr. Badawi, yes. 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 So macular hole, usually there's no PVD, as we all know, and that's something expected. So someone yesterday was asking me about training fellows, and I was telling them training fellows on macular hole is not very good. Epiretinal membrane is the best surgery because usually there's PVD. It's an easier surgery. So this case actually.
Ahmad, because as I said many times, okay, there is partial PVD. Over the macro hole, you can see even the operculum of the hole. And you can say it is not complete PVD with macro hole, but that is most of the time there is partial PVD with the macro hole.
Yeah, no,
otherwise the hole will not happen because of the.
Yeah, no, sure, but it's like for the surgery related, it's not a PVD because you have to induce it. Yeah. Yes. This is actually a very unique case because this patient also has asteroid hyalosis. And we know that asteroid, you have very adherent. So it's like, so here, and you can see the fellow operating, and we tried and he could not get a PVD. And my question to the panel, and maybe we can start the other way, Dr. Singh, so you have a case of, let's say, a macular hole or asteroid or something else, and the hyaloid is very adherent. You tried the suction several times, it's not working. What's your next step?
How PVD starts. He presented it at academy and complicated. And he has beautifully shown that PVD starts with nasal to distance, inferior nasal and superior temporal. Nowadays, when I have changed my site of initiation or for a PVD, earlier I used to do nasal. Then paper has shown that nasal is the toughest case. So our fellows also now we are telling that start just superior temporal or inferior temporal to distance.
Okay.
The area you will always find a pocket.
Okay.
And I'll definitely do just like this, staining using the butter. But if it doesn't work, the next step is I'll switch to a soft tip.
Soft tip,
and
okay.
Go for 600 vacuum. And what I do is I keep rotating that soft tip around the disc for some time. Be patient. Your time will come. So I tell your fellows, don't be hurried to grasp the bleed. Keep moving it and it slowly starts separating. If it doesn't, then I normally keep a backlash without soft tip, which has little wider holes. And it's also important to stay perpendicular to hyaluronic. Sometimes they are at angle, so they are not able to grasp it. So again, that's another thing. If really I am not able to induce, then there is an option to increase the size of one of the board and go for 23 gauge soft tape. That will definitely be the. But that nowadays will be that.
Okay.
But if in a tough case, you can do like that.
Dr. Abdallah, what?
I have some experience with steroid hyalosis. These are the toughest cases.
Yes.
And with all what Dipendra said, sometimes you cannot even at even the highest pressure.
Yes.
So what I do in this case is finally there is one barbed needle with suction, both. So you go in this place, the infratemporal, and you engage superficial. It needs some experience. You engage and you suck at the same time.
Yeah.
So you use both of them. This is number one. Number two, if you fail with the Thanos scraper outside the arcade, you try to open a hole with some scratching. You open a hole, then you try to elevate the hyaloid. Then here comes a very important point. Pulling on hyaloid most of the time causes peripheral death in such cases.
Yes.
And steroid hyaloids. What I do not pull so much, and I do what I say radial incisions in the posterior vitreous phase. So I go like this, and I start to peel easily. So I do not pull like the whole circle altogether. So I don't get a cone. If you get a cone in a steroid hyalosis, you will end up with a large area of tear. This is my experience.
So I think you have to be very careful when the hyaloid is very adherent. Dr. Beda, do you do anything different? Do you use the PIC
Yes,
sometimes?
it's start actually with the active suction, like everybody
Yes.
does, and there is a study showing the presence of a bursa temporal
Yes.
the edge of the optic disc, between the disc, and this is a
Premacular
site which
bursa.
can induce. If I fail with this, and this occurs sometimes, I use a pick.
Yes.
A pick and come to the edges of the disc and move it
Yes.
to the periphery. In fact, this eventually works in detaching the hyaloid. Like Dr. Abdullah said, in one case I failed to. In one case of asteroid hyalus, I failed to remove
Yes.
it. In diabetics, this might occur also in diabetics. You might find. However, in diabetics, you can go to the periphery and induce peripheral induction of the posterior hyaloid and then complete everything.
Yes. Okay.
Tenoscape are always a good idea, and it didn't fail at once with me these difficult things, but people forget about it. Tenoscape, you don't have to be over the fovea. Of course, you will come temporal, nasal, up, whatever. Wherever you create the hole, that's it. So
You know, Ibrahim, whenever you say tennis scraper in conferences or say they are going to damage the nerve fiber layer, you have to be, you get just open the hole in a localized place.
That's what I'm saying. Yeah.
Yes.
Just Tenoscape,
just
to create
just
this kind of hole
this,
there, and then you can lift everything out. Yeah.
And Abdurrahman, you
Not
do
go for the whole
anything
thing with
different?
Tenoscape, but no.
Similar. Okay. Yeah. So I think very similar. I usually try the cutter, and usually we skip the soft tip. Although actually we can try the soft tip. The idea of the soft tip, that the tip is more down, so it's nearer. And usually I would go to a pick, or recently I've learned to use the flexi loop. And again, that's here the fellow, and he's trying to scratch the retina to get into action. And you can see that's still he didn't get into the layers. And then he's getting there. Yes, that's a good. I saw your video in kids, and then he got into action and he got it up. So I think you need a sharp dissection, and the reason is the vitreous is multi-layered, and when it's very adherent, you're just getting to the inner layer. So you need to really get under the whole layers.
Just one more points in proliferative diabetics with a steroid.
Yeah.
So the point is proliferations cannot get through this very strong phase of the vitreous, cannot pop into the vitreous. They keep under this very tight surface. So whenever you remove this, you get horrible bleeding. Sometimes it's a diffuse and you cannot identify. So you have to be very careful because they cannot, like ordinary vitreous, they cannot go through the cortex of the vitreous. The cortex is very tough. So they keep under and proliferate under the cortex. So whenever you see a steroid hyalus with proliferative diabetes, you have to be very careful.
Yeah, these cases are difficult because, again, you have two reasons. So it's very adherent hyaloid. I think comes to the point where Dr. Osama was commenting on. So here, again, the vitreous separated off the center. We're trying to extend here, and I think you have to be careful. And then the vitreous is separating a bit more, but then here it's stopped. The question is what to do. Shall we, shall we remove all the vitreous and do vitreous-based shaving? Ibrahim, you like vitreous-based shaving, right? Yeah. Or shall we just say, no, this is enough and just leave the vitreous? So I think... So let's say it's adherent here, you will still try to separate it, right, and get a separation. Okay. And Dr. Beda, would you vitreous-based shaving as well? Vitreous-based shaving. No. And Dr. Abdullah? Shave in the morning or shave during the surgery? Yeah. Dr. Singh, shave or no shave?
Yeah, I think if I get one small focal area of attachment, I normally work around it, and sometimes if there is a small tear but rest of the vitreous separates, I am okay with that. But of late, I am doing a lot of interface vitrectomies. All these cases with attached retina, it works beautifully under air. So and you can see that convex interface going meniscus converting to concave, and it's a very faster and probably safer way of shaving.
Right.
Uh,
Abdurrahman, shave or no shave? Shave. Okay. All right. And Dr. Osama, you asked the question, so what do? You tell us. Shave or no shave? Let's say, let's focus on this case. Like, yeah. Yeah, I in general I don't shave even in retinal detachment, primary retinal detachment. I just try to remove what I can see, and over the break I just remove the vitreous. But even the rest I don't shave. And in macular disorders, I just go until things stop, and that's it for me. So that's the answer for this differences in opinion. And okay, it comes here again the second point: peel versus flap. And this is an old video here, and I'm doing a flap. And you can see this is a stick-on lens, so a small central view, and you can see here the peel, and then fluid air exchange and gas. The question is, I think if you have a small hole from less than 200, less than 400, what I tend to usually to do for these small holes is just separate the hyaloid, and usually they close. If it's, sorry, less than 200, like a very small hole. From 200 to 400, the question is peel or flap. And more than 400, I think that's another discussion. So my question is, if it's between 200 to 400, the usual, like the middle size hole, would you peel or flap? Peel. Right. Yeah. Okay, so again, we're talking about smaller than 400 peel or flap. So I do like Dr. Ibrahim. I just do a peel, and then Dr. Bida, what do you do? These smaller.
Holes between 400 and 650. These holes were addressed in the Manchester study.
Yeah.
And they reported a 98% closure rate with complete peel without flaps.
Yes.
So complete peel, it doesn't matter. It doesn't matter.
It just keeps surgery easy and simple. With the flap, it becomes all elusive. Yes.
Ahmed, what I
know.
do, and it is received good all over. So I do like localized peel. One vertical incision, ILM, then I do the lateral flap, and I cover the perimeter with the flap at least half the thickness of the hole. Then I make sure that the nasal part cover well, and it works. So it's just a localized small flap, and it works well for me.
Okay, and Dr. Singh?
I do ILM flap for all holes.
All holes, okay.
And I think we had this discussion earlier in different meetings.
Yeah.
Even before ILM flap came, somehow I was very concerned about conventional peeling which goes across the hole. And I always used to feel that the edges of the hole, they have a very vital, important tissue which gets avulsed when we remove ILM completely over it. And now Muni's and group's functional and morphological classification is talking about photoreceptor layers in the arms of macular hole. Probably that also, substantiates what we used to feel. So my approach for smaller holes and even for medium-sized holes till 600 microns is to have a very small single flap, which is a wedge-shaped flap, superiotemporal. And I remove all the ILM around, but I leave that wedge and I just place it over smaller holes.
Right.
So we did a study to find whether it is harmful to retain a flap in holes less than 250 microns. And we have published this also. It was not found to do a harmful effect on these smaller holes. somehow the number was small. We couldn't get whether it was visually beneficial to retain flap for these cases. But for medium-sized holes between 250 to 400 microns, the visual acuity was better in flap group versus no flap group.
Right.
We still need to validate this in a bigger studies that whether and why flap for all is if you are doing it with one technique, it becomes easier for you rather having two different techniques, conventional versus flap.
Right.
One thing also, Dr. Salam, is to cover or tuck. So
Yes.
to cover the hole allows for more speedy functional recovery.
And more like primary closure,
And
right?
you're more private.
But with
If you like tuck it inside, this will interfere for some time. Although studies prove that after 3 months, almost the same, the outer lid.
So I have one observation, one question. The observation, I used to peel small holes completely, but when I did a flap, I really find good function better. Maybe this is an observation. The second question is, if the decision is to peel, did you think the area of peeling will differ or affect? So if you peel, will you peel from the arcade to arcade, or it's just small peel?
Yes, a good point. I peel a small area, and I think that in case it doesn't work, I can do something else. But I just peel a small area around it. Dr. Yufeda, you had, yeah.
I commenting upon the extent of peel, I usually don't reach the arcades. Somewhere between the center of the fovea and the arcade with complete peel. With a flap, yes, flaps can work, but this will increase the time of the surgery and increase the risk of trauma. And eventually, I think in my hands, a complete peel or ILM flap are equal.
That's what I want to confirm as well, because people said, okay, better function, but in the Manchester study, they look for the function. The vision has been affected when you do the whole thing without a flap. So it was a big study, by the way, and big number of cases. Okay, so ILM peel alone doesn't make the vision worse or anything, or the flap make it better or not. There is no difference in the vision issue, the vision outcome. But as you said, Dr. Magdi, it is definitely with the flap and more maneuvers, you are always prone to have problems. Maybe you find it not inferior and it's giving the same effect, but what I'm saying, I need someone to look for the problems which is coming from the flap over the long run, with every time you are trying to complicate surgery, which should be easy. That's all.
Do anyone of the panelists experience after making a flap and positioning, when you examine the patient after surgery, the hole is still open and the flap returned back to its place? Yeah.
Yes, that's why there's always the part of the flap. I do temporal flap, so I don't do like the 360 inverted flap. So the temporal flap. So when you pull, you have the distance between the vertical incision, the ILM, and the hole. It has to be long so as to cover the hole and extend nasally for some time. So whenever I do fluid air exchange, it gets iron or pressed under the expanding bubble of the air, and if the ILM retracts, it won't retract till the edge of the hole. It will retract a little.
No, I mean, you find the flap returned as if you have not made a flap before. It returns back to its place. No, in two cases with an optimal size temporal flap, I found the hole is still open and the flap returned back. And when I de-interfered, I worked for the complete peel, and it closed.
Yeah. So I think on this one is to conclude is there are lots of issues that can happen with flaps and peels, and I think maybe the Manchester study is a good one, and you can see here differences in opinion. More than 400 or more, let's say, than 600. These are large ones. I think you need to do something different. So maybe ILM flap or hydrodissection we're talking about. Blood patches as well, I've used it. It works well. My only worry is that the blood may damage the RPE. But again, in these cases, their function is already compromised with large holes. And then it comes graft from ILM to anything you can find at home and just graft it in. And people have been using anything, right? From anterior capsule to tenons to amniotic membrane to retina.
You are right. It's literally, I had one case I'll never forget, actually. It was traction detachment in diabetic patient or whatever. And when when he was sent because of big macular hole, and when I went back, there is no ILM, there is nothing. Simply, I took part of the peripheral membrane over the arcade and just I put it there.
Yeah, anything you can
imagine
find at
it is
home.
close and this vision better. Okay, anything, even dull tissue, even fibrous tissue like this, it's just a scaffold for any cells to be on and can give.
And I think here the vision, in my opinion, does not improve. It's just you're closing it for, you're just trying to close it, or.
What was my question for the 400 and less? When most of the studies, even before the ILM flap develops or whatever, they were giving you 95% to 98% of cases will close without anything. Why you are not 80? No.
No, he's saying like in the old days, it was a very successful surgery. Why to reinvent the wheel, right?
That's what I'm saying.
Yeah.
It's some says shows 80, but some says 95 or 98. And why I'm saying this, because I did audit for all my cases over 7 years.
Yeah.
And just I found 95, 98% with ILM peel. So why you are adding more? What the ad will give you any more? 100%, for example? I don't know.
Yeah, and that's an example of whatever you can find at home. So this was a lamellar hole patient, and then after that, in 2 years, she became a full thickness macular hole. Not very common with lamellar hole, but that happened in her. And then I think we operated several times, and at the end, we just blocked it with amniotic membrane. Her vision never improved really. But an example of this. Please, yes. Thank you so much. Thank you. We're getting there. I think this is the end slide in a way. Lamellar macular hole, just a reminder that there are two types, tractional versus the degenerative type. The one on the side there is a degenerative type where the membranes are thick and the retina is really, there's degeneration in the retina. I think you have to be very careful in these patients because surgery is not as robust as in full thickness macular hole. So don't offer surgery for these patients unless they are really getting worse. And I think that's my advice on this. This is data from actually a nice study there, a multi-center study. 10% of them get full thickness macular hole, and after vitrectomy, they can get also full thickness macular hole. So just be careful about operating on these patients, especially the neurodegenerative one. And again, I think the suggested approach is very conservative to spare the fovea and even spare the fovea with ERM peel, and some studies suggesting ILM flaps and sparing the fovea with ILM flaps, but I don't do this. I just do an ERM peel sparing the fovea. Maybe any thoughts on these lamellar macular holes? And yes, please. Yes. Yes. I think you have to be very careful because they are actually, the fovea is thin, and I try to be like very conservative. Again, this is a patient who had significant cataracts, so we did combined, and then you can actually, in this case, actually was also like this, the hyaloid was very adherent, which is unusual. And then you can see here there's still the epiretinal membrane after removing the hyaloid, and then removing the epiretinal membrane. One tip here for photography is don't use a straight light, because you can see the image comes very bad with straight light. So if you're keen on good videos, use a wide field light. So that's not to do. And I'm trying to spare the fovea, and you see it again. You'll see it better with the intraoperative OCT picture. And this patient had vitreomacular traction and vitreopapillary traction, and the epiretinal membrane and the lamellar macula was really interesting, and everything was stuck down. And you can see here the center. And then it's here the flaps. And then after that, I usually trim the flaps, and I don't do ILM flaps, but some people recommending ILM flaps sparing the fovea. Dr. Beda, I don't know, what do you feel about this? Or
in general, patients with lamellar macular holes, usually they have good visual acuity, and concern a lot.
Yes.
I don't go for surgery in these cases, except if there is something else beside the lamellar macular hole. And I think you don't need to make an ILM flap or something like this. Just remove.
So I think be careful in these patients, because surgery is not as robust, especially in the degenerative type, under promise and I'll be very careful manipulating the fovea in this patient. Okay, well, I have a quiz if anyone is interested. Here, which ones? I like these specific things, PVD, not PVD. I find them useful for teaching. So VMT, we know that there's no PFD. Epiretinal membrane, what's the feeling? PVD or no PVD? Yeah, usually PVD in most of the ERMs. Some of them do not, but most of them. So again, it's the nicest surgery to train the fellow, especially a pseudophakic eye. So they operate, and then you come and scrub and peel the ERM, and then they can finish the surgery. So it's a nice surgery for the fellow. And then macular hole, we know there's no PVD, right? Asteroid hyalosis, no PVD. Myopic traction maculopathy, most of them, there's no PVD. Diabetic TRD, we're just talking about. 97% of them do not have PVD or have even vitroschisis as well, right? And then this comes important, retinal detachment with horseshoe tear. This is usually a PVD one, and that's why the horseshoe tear, but retinal detachment in young patient with dialysis and atrophic retinal holes, no PVD, and that's why we were talking about this the other day. These cases are best suited for buccal. Giant retinal tear, yes, in children be careful because they may not have PVD, although they have a giant tear. But the majority of them would have a tear, but in kids they may not have PVD, and that's a difficult one. A syndromatic, yes.
Cases of giant retinal breaks in young people, probably you might find a case of 360-degree giant retinal break. Induction of PVD in these conditions, probably impossible to do.
Right.
Do you have any thoughts how to induce PVD in those patients with?
And there was one study from South America suggested in these patients, although nowadays we don't do combined buccal vitrectomy for giant tear, but it was suggesting combined buccal vitrectomy for young patients with giant tear, which I think is sensible. I don't do that, but I think it's sensible. And I think if they have giant tear without infolding of the flap, maybe buccal only is a good option and treat it like a dialysis if the flap is not folded. Yes, that's one, especially if it's high. Yeah, if there's no significant displacement, I think you can treat it as a dialysis, especially if it's not so extensive.
If a giant retinal break is treated like a dialysis, you will use a lot of cryo therapy. And do you vitrectomy or the buccal?
No, so actually
So dialysis, we go for the buccal.
Yes.
So giant retinal
so
break.
even with big dialysis, what I do is I just buckle them. I don't do cryo. And then I come back after a month or 2 months and then do the laser in the clinic. Because basically when you do a buckle, and that's something actually nice to discuss. When you do a buckle, if you buckle with no cryo, the retina is going to flatten. But why do you do the cryo? Because that, especially if you're doing a localized buckle, 6 months down the line, the suture will weaken and the tear is going to open. So you want a permanent treatment. So in these cases, I would do like after a month or after even 2 months, I would do the laser in the clinic.
However, if you finish up the surgery, after doing cryo, you should do gentle cryo until the retinal pigment epithelium appears yellow. And this would be, I have never seen a case of PVR after dialysis with a buccal.
Yeah, this one was like, it was nearly like a giant break, but it was a dialysis. It was nearly 3 hours. So I thought it was going to be too much cryo. And then I had cases where the cryo did not work. I had one case where I actually finished and I forgot to do cryo. So in these cases, I would just laser them later on. If
you have a giant retinal break, would you go for scleral buccal for this without vitrectomy?
I think if it's a young patient and there's no like a significant displacement, I think I would try a buccal.
Buccal and gas. So if the giant retinal break is inferior, what to do?
I think it depends. If it looks nice, then I usually with buccal and drainage, I put air. I may put gas.
Even with a large inferior retinal break, giant retinal break inferior, you do buccal and gas.
The only giant break I did with buccal was just one case.
Yes.
And was no infolding.
Yes.
But I did big dialysis with just buccal, and
it works.
It works very well.
Retinal tear, if there is no detachment, then you can just barrage it. But if it is a giant tear, I think most of us, I think, will go for a bit detachment,
Yeah.
go for vitrectomy. But how is your experience about ERMs and macular puckers in these cases?
In with giant tear?
Giant tears, they get successfully reattached.
Yes.
But problem comes.
They have higher risk of ERM.
So do you try to peel ILM
No.
in primary surgery?
I usually don't try
But
to do
giant
anything in
tears.
ILM. No, even in giant break, I don't try to do anything. I just try to deal with
And
that,
do you-
and later on,
You try to do something for RPE at the base of tear? You try to scrape off or something? No?
yeah, no, they have higher. Yes, yes, yeah,
Sometimes I do fovea sparing ILM for giant tears.
yeah.
Yeah, I think
Yeah.
it works well. But if you are putting oil, you can do ERM removal at
I
the
try
time.
to use the gas on those patients,
I
or
think they
sometimes I
have a
need the
tendency for
PFCL.
this. I think they have, because see what we are doing in prime rhegmatogenous fresh detachments is we are doing pre-op OCTs. If we see Ballard, that foveal thinning, which is, so I try
Oh, I
to
don't
do a
have it.
fovea sparing ILM. But if I have a nice fovea on pre-operative scan, I feel over the fovea. GRT, you are not able to see fovea because many times it's covering the fovea.
Yes.
So to be on safer side, if you are trying to peel, then probably it has to be fovea sparing.
Yeah.
Islam, I have a question regarding localized VMT. If you have a localized VMT, it's than 1,500 macron. We have an evidence from the RCR network college that pneumatic vitrolysis may solve the problem. We can inject 0.3 CSF8, and I have more than 3 cases succeed to detach the amyloid just by a simple procedure. If it fails, we can go for vitrectomy.
Yes.
In experience,
my experience is not good really. I tried a few cases that did not work, but I agree, and they're calling, I think, even up 70% success or even more.
80%.
Yes, we see yes.
I have an interesting story regarding localized VMT. So that patient I was following up for a long period of time, delaying surgery. Then she came just complaining of diminution of vision, metamorphopsia, and so I scheduled her for surgery. Okay, and at the day of surgery, she told me, "I'm fine now, doctor." So I went quickly while she is on the gown downstairs to the clinic, did OCT.
Yes.
It vanished.
Yes.
So just be
We had a
careful.
patient like this with a small macular hole as well, which is interesting.
Small macular hole.
Yes, I'm close.
I have another patient of actually my
Yes.
mother of a colleague.
Yes. Yes, yes. Yeah. Yeah. I think it was a study of Dr. Ahmed Mansour and colleague from Lebanon, and they collected lots of pieces and they saw like small holes. Yeah, I've tried as well, didn't work. I think they were talking less than 200, right? Yeah. Idiopathic. Idiopathic. Mm. Yes. 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 No, it's interesting. Well, thank you so much. It's we don't want to end the discussion, but we can discuss more over coffee. And thank you so much. Thank you for the esteemed panel as well. Thank you. شكرا. تسلم ايديكم.